Hello, everyone, and thank you for joining us today. My name is Carla Alegria with the National Center on Domestic Violence, Trauma, and Mental Health. Today's webinar follows our webinar series on opioids, trauma, and domestic violence. This is your brain on drugs. This is your brain on trauma. Today's presenters are Sean Marz and Dr. Fred Rottnek. Facilitating today's webinar is Dr. David Shern, and briefly introducing the center in the webinar series is Dr. Carol Warshaw. Before we get started, I would like to go over some technical details of the WebEx software that we'll be using for today's webinar. Many of these details are explained on the Using This Webinar System tab in the center of your screen. You can switch the screen from the slides by clicking the down arrow next to the Using This Webinar. Please be aware that your screen might look a little different depending on whether you're using a Mac or PC. On the right-hand side of your screen, there are multiple boxes. Third from the bottom is the chat feature. You may have to click on the chat cloud image on the bottom center of your screen to open your chat box. This feature will allow you to provide feedback and share resources with your fellow colleagues, as well as get in touch with the trainers or myself if you have questions regarding the training content. You may contact Angelica Medina, also at the center, if you have questions troubleshooting the WebEx software. To do this, click the down-facing arrow and select the person you would like to contact. You'll see a lot of options, but for this session, you'll want to select all participants. If you would like to respond to a question from a trainer or to contact the center staff anytime during the session, you should click on Angelica Medina to privately contact her if you are in need of troubleshooting the WebEx software. So let's test this chat feature. Will everyone please go to the chat box, click on All Participants, type in where you're calling from, and then press Enter. Perfect. Thank you all very much. While folks can get a lot out of the chat feature, there are times when it moves really quickly and can feel distracting. If this is true for you, feel free to minimize the chat box by clicking the down arrow next to where it says Chat. You can always open it again with the same arrow if you choose. We will be providing live captioning during this webinar. Below the chat box, there is a media viewer box. This will contain the captions. If you do not want to see the captions, click on the down-facing arrow next to the word media viewer, the same way you might if you want to hide the chat box. Time permitting, I will be moderating the Q&A at the very end via the chat box. And at the very end of the webinar, you'll be taken to a brief survey. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, return to the email you received with the original webinar link and re-enter the training. Sometimes the sound cuts out due to internet connection, so feel free to call back if this is a problem for you. If you're experiencing technical difficulties and are unable to contact Angelica Medina, you may call the WebEx tech support to resolve any issues. That phone number, which I'll post in the chat box, is 1-866-229-3239. And again, thank you for joining us today. I will now turn it over to Dr. Carol Warshaw.
Thanks, Carla, and thanks, Angelica. So I'm really pleased to have you join us for this new webinar in our joint series on opioids, trauma, and domestic violence. It's co-sponsored by us at the National Center on Domestic Violence, Trauma, and Mental Health, and the CTIPP, the Campaign for Trauma-Informed Policy and Practice. And the National Center is a U.S. Department of Health and Human Services Administration, Children, Youth, and Families, Family Youth Services Bureau, Division of Family Violence Prevention and Services, one of the 4 national special issue resource centers. And ours is obviously on the intersection of domestic violence, trauma, substance use, and mental health. And our work is partly designed to promote an accessible, culturally responsive, and trauma-informed approach for the DV and domestic violence and sexual assault fields, and what we call an accessible, culturally responsive DV and trauma-informed approach for the mental health, substance use, behavioral health, and child welfare fields. And we do a lot of our work in a couple of different ways. We provide a wide range of training and technical assistance resources through our research work and policy activities and through public awareness. And as Dr. Shern is talking about, CTIPP part of what we do is add in another layer in addition to the thinking about trauma is in the opioid space is thinking about the role of substance use coercion and coercive control specifically targeted at survivors' use of substances, both in terms of practice and public policy. So now, Dave, I'm going to turn it over to you, to Dr. David Chern, who's the Senior Science Advisor at the Mental Health America and the Chair of the Science Subcommittee for CTIPP.
Thanks, Carol. That's a terrific introduction, and we certainly appreciate all the great work that is done by the center. I'm just going to talk a couple of minutes about CTIPP, an organization that several of us founded a couple of years ago now that has a mission really to create a resilient and trauma-informed society, and we do that through a number of venues. We oftentimes advocate for public policies and programs at the federal, state, and local level that are responsive to these issues. And in that regard, we're really proud of some work we've done recently, along with many, many colleagues, working with the Senate staff initially to develop some language about trauma-informed approaches to issues that individuals may experience in a broad sense. And we were successful in terms of getting that language incorporated into the opioid bill that the president recently signed. So there are now specific language in the opioid legislation that addresses the importance of trauma, preventing trauma to drive down the rates at which people become addicted to opioids and other substances, as well as trauma-informed approaches to treat individuals with substance use conditions, in this case, of course, specifically related to opioid conditions. And so we'd like to encourage you all to visit the CTIPP website. If you just Google CTIPP, the homepage will come up, and there's resources there that I think you'll find interesting. And it's also an opportunity for you to join CTIPP. It's very affordable. It's free, and we're trying to build kind of a national network of individuals from across the different sectors who are interested in working to create a trauma-informed and resilient society in our country and really around the world. So we encourage you to join them, to visit the website and join the organization. You know, as we began to work on the opioid problem last year, we assembled through our science and policy committees a group of individuals to start to look at the scientific base for understanding some of the antecedent conditions to persons developing opioid use disorder. And we're not surprised to learn, in fact, we knew going in, that individuals who experience trauma in childhood or later in life are at increasingly high risk for the development of substance use conditions. And it's based in part on that logic coming from the trauma research field. We were able to propose both prevention strategies, which reduce the experience of trauma, as well as treatment approaches that are trauma responsive. You know, one of the things that has made the work in trauma more and more compelling is our understanding of how trauma, particularly early trauma, as individuals are in very critical brain development phases, actually becomes encoded, biologically embedded, affecting neural functioning, immunological, and endocrine functioning in a way that predicts initially problems in behavior, such as mental health problems, that subsequently can be associated with the development of substance use conditions, and then later other chronic illnesses leading to excess morbidity and mortality among these persons. So we really have a life course perspective, and we understand that the effects and the way these become biologically embedded has added a tremendous amount of heft, if you will, to the argument when we speak with policymakers because of the compelling nature of this information. Today, we'd like to, in this continuing series that Carol mentioned earlier on, we're continuing to explore these issues today, and we're really lucky to have two excellent presenters who are going to talk to us about an integrative approach to understanding both the effects of trauma on the brain and how those effects can be reflected in terms of the treatment that's effective. And so we have, as was mentioned earlier, Dr. Fred Rottnek, and Fred is on the faculty at the University of St. Louis. He's a physician, board certified in addiction psychiatry. Has done some great community work and sort of, I think, showing his commitment to these issues. Great community work in working with homeless populations and populations in correctional settings. And he also is the medical director of the Assisted Recovery Centers of America and works with the Missouri State Opioid Response Team. Fred's going to be joined by his colleague from Alive and Well, Sean Marz. And Sean is the Training and Technical Assistance Director in trauma-informed care at Alive and Well, and has had many years of experience working with and training people to use trauma-informed approaches. Sean has a very impressive resume. Among that, he helped to craft the Missouri model, which is a developmental formulation for understanding trauma-informed care. So both Fred and Sean represent terrific perspectives and resources with regard to these topics, and we're really lucky that they can join us today. And Angelica, for some reason, dear, I am not being able to advance these slides. So if you could do me a favor and advance them to the title slide for Fred and Sean and pass the controls to them, I would be there. You go. I'm very, very pleased. I don't know what went wrong, but for some reason, although I was clicking away, I wasn't able to get anything to move forward. So with that being said, I'd like to now turn it over to Fred and Sean to educate us with regard to this is your brain on drugs and this is your brain on trauma. Fred and Sean?
David, thank you so much for this introduction, and I just want to share that Fred and I are very excited and very honored to be here today and sharing this with you all. Fred and I represent Alive and Well Communities, and Alive and Well Communities is an organization that's designed to really address toxic stress and chronic trauma in the communities we have the privilege of serving, recognizing that we can't wait yet another day nor another generation to stop the impact of trauma. So using the science of resilience and trauma, we work at all different levels of community in order to create these Alive and Well communities. And we also want to share that Alive and Well Communities is a proud organizational partner with CTIPP as well. So moving right along, we want to just share with you that we have no disclosures to share. And then getting into our objectives today, just sharing that we hope to really set the tone that the lived experience of trauma and its vulnerabilities, and really highlighting how then addiction, as well as opiate use disorders, then this is part of this process. So what we'll be doing is we'll be starting by talking, just laying the foundation of trauma and the neuroscience of trauma and briefly reviewing that, and then really getting into the role of medication-assisted treatment, as well as understanding the interplay of multiple modalities, and really hoping that through this information today we create a common vocabulary, really not just for treatment implications, but for policy implications within organizations and across systems. So doing this, what we want to do is understand the impact of trauma on the brain. And I want to start by just kind of level setting that when we talk about trauma, typically we think about these interpersonal events or experiences. We typically think of things like neglect. We think about abuse, parental divorce and separation. But we also want to make sure that as we think about these stressors on the brain and body, that we're also understanding our adverse community environments. And that language comes from BCR as we think about the pair of ACEs, So thinking beyond the interpersonal experiences and understanding things like community trauma, thinking about the impact of community violence, poverty, racism, discrimination, and its impact on our ability to thrive and develop. So as we think about the brain and understanding these stressors on the brain, wanting to understand that trauma, especially experienced in childhood, can derail healthy development, but trauma experienced at any point throughout the lifespan can also have crucial changes on the brain structure as well. So as we think about healthy development, we want to recognize that as a result of the experiences of those acute and often prolonged stressors, of those traumatic experiences, whether they're interpersonal or community, that this derails that healthy brain development. That what we would like to see is that synaptic density healthily growing in the prefrontal cortex. But as a result of the trauma and the impact on the brain and the neurochemistry, what we see is that there's an increase in norepinephrine, increased dopamine, as well as endorphin release, that those glucocorticoids as well as adrenaline all have a really profound impact then on the brain development and our ability then to function as a result. That as we think about brain development, we want to understand that as a result of that traumatic experience, that it has an impact on the brain and then subsequently on our body and our potential to engage in those activities of daily living. So just kind of in review, seeing how the impact and the lived experience of trauma can really kind of derail all sorts of aspects of how we engage with the world around us, not just in terms of the chronic illness that may develop, but really also in our social interactions and our ability to thrive, our ability to live alive and well. So as we think then about our response then, as a result of those abnormal experiences, as a result then of the changes in the body chemistry, as a change in the dopamine levels, we can see that it may lead then, that milder stressors may then lead to hyperarousal or even hypoarousal. That as you look at this red line here, that this red line represents a normal response as a result of those acute and chronic stressors. That as a result of those changes in the brain and subsequently in the body, we can see this hyperarousal, or what are sometimes referred to as those acting out expressions, as well as hypoarousal. And recognizing that this red line is that experience in the brain and body as a result of those abnormal events, as those stressors that may be interpersonal as well as community traumas. So one thing that we want to recognize in moving forward is we want to recognize that in the opioid epidemic and this time in this space, how we're really using the science differently to inform and understand that we need to have a health response to addiction. That as a result of trauma, as a result of the science of addiction, understanding that our tactic in addressing this needs to be very different, but also wanting to recognize and name that in other times and spaces, as we've looked at addiction, not using the science to appropriately inform intervention and seeing sometimes, in fact, the criminalization of addiction as a result of that science not being used. So with that, I want to go ahead and turn it over to Fred to move us forward.
Thank you very much, Sean. My interest in this work came about after many years working in homeless health care and then over 15 years in correctional health care, and then having the opportunity to take a deeper dive into addiction medicine now that it's been recognized as an official specialty in the field. What we're going to take a look at now is, now that Sean has given that great introduction to trauma and brain structure and brain chemistry, we're going to take a look at opioid use disorders and the similarities that we see in some of these issues. one of the things that's always a challenge speaking to students and residents about opioids is when we're talking about use disorders, we want to talk about cravings. And that's something that we don't typically talk about in healthcare. We talk about vital signs, we talk about physical exams, but we also talk about cravings. What's very important for us moving forward as well is this idea of brain structure and the neurotransmitters that Sean mentioned already. On the bottom of this slide, I mentioned that we're going to be focusing for the next few minutes on dopamine, because dopamine is the big driver when it comes to neurotransmitters and opioid use disorder. A phrase that I stole from Sean, actually, and I'm sure he stole it from somebody else, was this idea of the lizard brain and the wizard brain. The lizard brain with the brainstem, with the issues surrounding that, the structures that control our most basic human functions like breathing, like heart rate, sex drive, drive to procreate, hunger, sleep, all reside in the brainstem. However, we know that executive functions exist in the frontal lobe, the part of the brain that develops last, and is also the part of the brain that will often control some of our more primal drives. Anybody who's raised a teenager who has lived with a teenager knows that the brainstem develops first, the executive function develops later, which is why we know with teens in particular, impulsivity is part of the normal maturation process, as is impulsivity control. So again, let's take a look at the 4 primary signs and symptoms of what we now call substance use disorder: cravings, loss of control, tolerance, and then continued use despite adverse consequences. So most basically, when we ask, what do medications do for the brain? What they do for the brain is help restore the balance between the lizard brain and the wizard brain, the basic drives and the impulsivity that can be tempered by the prefrontal cortex. I want to be clear right off the bat, not everyone needs medications. We know that only about 10 to 15% of people in the United States access medication and health care to address an addiction. However, we know with opioid use disorder, particularly when we see heavy use, polysubstance use, and early age of onset, medications have a great role to play in helping restore neurotransmitters and giving the brain time to heal. That's what we find with the role of therapy as well. When our brains can calm down, when our neurotransmitters resume homeostasis, when the brain heals, therapy can be more effective. And since our brains are different, so is the extent and process of healing. So let's take a look at the medications we're talking about that affect the zone right in the middle of the brain, that area between the neurons, as we see these little white squiggly lines where the neurotransmitters conduct impulses. And let's talk about a simple model that can help us understand the role of dopamine in why people use opioids. Not to give anybody PTSD back to algebra, but let's take a look at our X and Y axes here. Our y-axes we can think of this in a couple different ways. We can think of this as our emotional or psychological state, with the normal zone being the white zone, the green zone being a euphoric state. Some euphoria is a good thing. Too much euphoria can get us into trouble. The red zone we can think of as a withdrawal state. We can also think of the y-axis as a dopamine effect or opioid effect. The x-axis in this case is time, the acute use versus chronic use. Most opioid naive patients, except for perhaps the 10% that just innately have a negative response to opioids, would, let's say you took some OxyContin today, If you're an opioid-naive person with an opioid-naive nervous system, you would bounce up and down between a normal and euphoric state over time. Now, what that period is, going from the area where you vacillate between the white and the green area versus the white and the red area, this period of time where you go back and forth between the green and white area, for some folks can be as few as 8 to 10 days. What happens in time, however, is our nerves actually upregulate. Think about receptors, and think about receptors as Lego blocks. If you have the standard 2x6 Lego blocks, again, back to those of you who have raised children, if you didn't play with Lego blocks as a child, you probably stepped on one as an adult. Think of how you plug in a small Lego block into the bigger Lego block. You get that snap. When that snap happens, dopamine's released. Once someone has a lot of dopamine floating, a lot of opioids floating around in the system, those receptors upregulate. A given nerve, for example, say you would have 2 receptors, you might go up to having 5 receptors. When your nervous system actually changes like that anatomically, your nerves aren't happy unless those new receptors, are plugged up by opioids. Then you move into this space from going into the white and green zone into the white and red zone. Many people who work with folks with addiction, you may know that somebody actively used that morning, but if you ask them when's the last time you got high, they might say 3 years ago, 5 years ago, because many people who use opioids on a regular basis are using opioids in order to stay out of the red zone. They want to feel normal, and they use in order to stay in that white zone of quote-unquote feeling normal. Now let's keep this slide in mind, and we can move forward to the next slide as our x-axis continues. Where the work is done for many of us working with folks with addiction is how do we help people move from the red zone back into the white zone, into a euthymic state? How do we help people find a way to allow their brain to heal, their neurochemistry to normalize again? Again, many people can do that on their own. However, some people need help, and that's often where not only therapy but medications can help. So the next few slides, we're going to take a look at what happens in this transitional area where we're trying to help people move from this red zone up into the white zone. One more graph, just so you know it's science, because there's more graphs, more science. Again, same y-axis where you have opioid effect or dopamine level, and we're going to talk about 3 specific medications. The reason we're looking at the opioid effect is that we know for people to have those receptors plugged up, if we're taking heroin out of the picture, we're taking prescription opioids out of the picture, we want those receptors to be plugged up so somebody is not obsessed with cravings. One intervention that we've known about since the 70s is called methadone. Most people know about methadone clinics. Methadone is a full agonist, meaning it is a synthetic opioid. We've used it for a long time. We've used it for many reasons. But in addiction medicine, we use it to help those receptors to be plugged up so that people's cravings are under control and they can engage more fully in therapy. There's advantages and disadvantages of each of these that we'll talk about in a minute. One of the medications that we're promoting more use of right now with the opioid state-targeted response is buprenorphine. Buprenorphine is typically known in brand names as Suboxone, Subutex, or Zubsolv. There's a few more formulations as well. I will call buprenorphine Bup from now on because it's a whole lot easier to say. The nice thing about buprenorphine, it's also a synthetic opioid, is that it has a ceiling effect. After a certain dose of Bup, for most people, you will have a ceiling effect of the opioid effect and also a ceiling effect of dopamine release. Physiologically, this makes buprenorphine a safer drug. People can die from methadone because people can die from the respiratory depression that excessive opioids create. This ceiling effect of buprenorphine allows it to be used more safely. The third medication that we'll talk about comes in a couple different chemical formulations, but the key is that it's an antagonist. When naloxone, think of it as a little Lego block. When it plugs up into the receptor Lego block and the snap happens, what happens is that it blocks dopamine release. In other words, I could take naltrexone, the depot formulation is Vivitrol. If I took that today and used heroin or OxyContin, the receptors would be blocked by naltrexone and I would get no opioid effect. We'll unpack this a little bit more in the slides coming up. Again, we'll start with naltrexone. It comes in an oral formulation where people can take one once a day or once every other day. The Vivitrol is the depot formulation, which lasts anywhere from 21 to 28 days. I tend to think of naltrexone as a protection against opioids because remember, it is not an opioid, and what it does is plugs up the receptor site so that opioids cannot have a dopamine push or a dopamine release. We'll have examples of how each of these drugs may be used once we introduce all three of the medications. The next medication is methadone. Methadone, again, a full opioid agonist. It is an opioid. This is well known to the medical community. We have lots of reports of its effectiveness and use in community settings. But it's highly regulated because it's also highly abusable, and it makes accessibility to these services much more difficult. But by being an opioid agonist, it does have a dopamine push, and it allows the brain time for healing and for neuroreceptors to normalize. I refer to methadone as an agonist as opioid use disorder treatment versus opioid use disorder protection that we talked about with naltrexone. Let's go on then to the third medication used in this area, which is buprenorphine. And on this slide are some examples of formulation of buprenorphine. Remember, bup is that partial opioid agonist. It's usually administered sublingually, even though now implants and soon a depot injection is going to be available as well. Again, as a treatment, as an agonist, what it does is allows the brain time for healing and the brain structure time for healing. Cravings are controlled, and then a person can more effectively engage in the therapy that they need for recovery. Research supports that this works very well in community-based practices, meaning any physician, physician assistant, or nurse practitioner can prescribe buprenorphine after they have the appropriate additional training for this. The reason that this is less tightly regulated than methadone is because of that ceiling effect and the much lower risk of overdose from misuse. So moving forward, let's tease these apart a little bit. This is a bit of a repeat of the slide we had before, but it gets back to what do addiction medications do? They give the body time to stabilize brain chemistry, reduce cravings, and allow the brain to heal. And again, when people are not obsessed with cravings, they can more fully engage in therapy and behavioral change. And since our brains are different, the extent of process of healing difference, and this is where medication treatment choice comes in.
So, Dr. Rottnek, I'd like to ask a question at this time. So, as we talk about these medications, and I know you said earlier that not everyone needs medication, but as we talk about this, is that true that not everyone needs medication?
I would say not everyone needs medication because people do not develop addictions in isolation. In fact, let me go to this next slide, and I think I can tease apart some examples of how we might use different medications. But to answer your question before we do that, we want to go back to always thinking, what's the context of the patient? What are the resources in that patient's life? When did someone start using? What was the severity of the use? And were other substances involved? Because if we look at our next slide here that takes a look and helps us remember there are other neurotransmitters involved in behavior and in not only behavior but how our brain and nervous system functions, we know dopamine is important, but it's not the whole story. So let's tease this apart and let's see if this answers your question. Excuse me, we went a little too far there. I mentioned earlier, it depends on context. So we'll come back to this question of who all needs medication, but I think this is one of those opportunities where we can look at protective factors for risky use of substances and use disorders or addiction. And this is where I think, Sean, from your background, you're going to see a lot of similarities. We know that we have protective factors that are environmental and protective factors that are individual. And this, again, not new science. This is something that the World Health Organization came out with in 2004. Environmental factors there, I know you can all see them on your screens for people participating in this, and also individual factors. What do you see when it comes to trauma with this, Sean?
This overlaps exactly with those protective factors that we think about when individuals experience trauma and then risk for what that trauma experience may lead to.
And I think it's important when I teach medical students and other health professional students, much like trauma can be cumulative and repetitive over time and create more severe outcomes and difficulties, you can see why if you start coupling trauma together with opioid use disorder, the outcomes can be magnified. Of the flip side to the protective factors are the vulnerabilities, and I think this is where we're going to also see similar incidences of environmental and individual factors when it comes to trauma, and it also comes to use disorder and risky use for opioids. Environmental factors here, the availability of drugs is a huge issue, especially in the United States right now, but many of these other environmental factors are here as well, and we see this on a daily basis. On the individual factors here, we see genetic disposition, we see trauma explicitly listed here from the World Health Organization, but something that is newer or at least more common since 2004 to discuss is the role of epigenetics. And we're seeing the impact of trauma on manifestation of gene expression and how that can be carried through generations.
So as we think about childhood trauma, is this in part because of the increased production of endogenous opioids that we see in the brain?
I don't know if I would say there was increased endogenous opioids because of trauma, but I think what we would see, you would see the inability of the opioid-naive brain in kids for that dopamine level to fluctuate quite a bit. Because there's going to be less opioids released when kids do not feel safe. Dopamine is the neurotransmitter that we associate. I always say, if you hold a puppy, you get a dopamine release. When kids have elevated adrenaline levels, elevated norepinephrine due to the stress response, due to cortisol release, those swamp the receptors and dopamine effect is minimized. So it just makes sense that if dopamine is low and kids have an opportunity to increase their dopamine level through the use of alcohol, opioids, or other drugs, that's going to compensate for their chemistry at baseline. Does that answer that question? Okay. Let's take a look, again, unpacking this a little bit more. There's sometimes in the addiction world, I don't think it's as common in trauma, but there's still a lot of work that we have to do about talking about the different tools in the tool belt where we can work with folks who have experienced opioid use disorder. And unfortunately, one of those areas is that many people still have this false dichotomy between medication treatment and psychotherapy. I firmly believe that medications can help the brain structure heal and chemistry recover. But if we look at some of these issues on this slide, we know that all the chemistry in the world cannot help people learn the skill sets that they need to thrive and to be successful. Therapy helps people reverse the conditioning that they've developed around opioid seeking. Therapy can help people build the skill sets that are needed to create stability around their social determinants with things like jobs, housing, and relationships. And therapy can also help people cope with the stressors that exist in everyday life. Just because we're helping someone with a medication to address addiction doesn't mean we're fixing their home environment, their work environment, their social environment. But we can help people develop a healthier response through therapy to deal with those ongoing stressors.
Including the stressors that may have led them to substance use and opioid dependence initially.
Exactly. We would hope that with medication therapy, we're giving people not only time to heal, but a time to normalize their chemistry, and then, as we'll talk about in a few slides, we can help protect them from some of these environmental issues that may not yet have changed, including the availability of drugs and other psychoactive substances. Some people do best with specific patient examples, and I know I often do. And I wanted to give an example here of what 3 types of patients might look like who might benefit from each of these 3 medications. Vivian Vivitrol, I'm really proud of their names. I came up with them on my own. Vivian Vivitrol developed her addiction following an ankle fracture at work. I always give the backstory that Vivian was a med-surg floor nurse who broke her ankle one day pushing a patient's bed down the hallway, a very common problem. Vivian, if we take a look at her life, she's an RN. She developed an addiction only after an iatrogenic start of a prescription opioid. She was prescribed an opioid post-op. Went home, and like many people in this field, wanted to get back to work quickly. Maybe she didn't engage in physical therapy because she needed to get back to work. Maybe she got more opioids than she needed from a physician that didn't prescribe properly, and she got addicted to opioids. Now, Vivian achieved success early in life. We know that our brains don't fully develop until at least age 25. Well, Vivian would not have been able to go through nursing school with an active addiction. She had developed an addiction later in life. For Vivian, she may not have needed a big dopamine push to get her off of opioids. She has a job, she has a career, she has maybe a family, and other resources in her life and her community to help her get back. And she can also look back to a time in her life where she was once very successful. She might just need the protection of getting transferred off of opioids through a supervised withdrawal process, and then maybe she would do well just by having the protection of Vivitrol on board. So if she did have a bad day and she thought about taking an opioid, the action of the opioid would be blocked by Vivitrol. So for her, moving forward with a protective medication might be the right choice. Let's move on to Suboxone Sam. Suboxone Sam started using substances as a teenager. Maybe he got into his parents' liquor cabinet when he was 15. Maybe he got some pill form heroin on the playground when he was 17 because he was afraid of needles. But maybe time went on to where he started shooting up because it was cheaper to shoot up and get a higher benefit by IV use than oral use. Sam started using as a teen. Sam's brain was affected as a teen by opioids. He likely needs some time for his brain to heal and his neurochemistry to normalize again. Sam probably needs a dopamine push, but not a big dopamine push. He would probably be successful on Suboxone to stabilize that chemistry. So for Sam, initial treatment might be best with Suboxone. Now let's look at Methadone Marty. Methadone Marty might have had the same pathway as Sam, but maybe Methadone Marty didn't have other protective factors in his life, such as a caring family, a stable home life, academic success, whatever the case might be. Think back to the slide we looked at a few slides ago where we had that ceiling effect with Suboxone, but methadone, you could increase a dopamine effect if you increase the dose of methadone. Marty might need a dopamine push higher than the ceiling effect of Suboxone. You can do that with methadone. So maybe Marty needed a higher dopamine push, so he needed methadone to initially calm down the cravings, to allow time for his brain to heal, and allow time for him to engage in therapy. Here's where I would like us to get a little bolder and a little outside the box on our thinking when we talk about medications used in treatment of opioid use disorder. And here's my question that I present to our participants today. Once on methadone, heroin, or bupe, are you always on methadone, heroin, or bupe? The reason I think this is a very important question for us today is we have spent so much time in the last 2 years talking about harm reduction and getting people into treatment that I think sometimes we've taken our eye off the ball of what do we work with our patients, how do we work to define success. The caveat here is that there is nothing wrong with harm reduction. It is essential because dead people don't recover. We have to keep our folks alive to give them a time to heal. However, we also have to move beyond milestones and markers that we have used in the past for addiction treatment success. And for most studies, successful treatment means people are retained in treatment. I think that is setting the bar too low. I think we would not be happy if somebody's hemoglobin A1C and diabetes was stabilized at 7, yet they had pressure ulcers, or they still had vascular complications, or they had neurological complications from problems in the past. We need to look at the role of medications in addiction, and particularly opioid use disorder, like we do in every other chronic disease state. What is the lowest effective dose of a medication, and what is the safest medication we can use for our patients? I say this knowing that a lot of the people who are participating today come from a therapy perspective, and those of us who are engaged in some of the medications used do not make it very clear what we are using for our meds and what is the goal of the medication intervention. That's why when we talk about this, I'm really trying to focus with folks I work with that we need to reassess our patients on a regular basis if they are on medications for substance use disorder, particularly, again, opioid use disorder. In this graphic, I'm proposing a way to think about using medication. Methadone if someone needs it. I think that's going to be a small subset of people who need a strong dopamine push, as we talked about. Many people who need a dopamine push and treatment to allow the brain to heal and for receptors to regulate will do well on buprenorphine. Once people have their time to their brain to heal and regulate, we need to check back to see what else is going on in your life? Have your other resources, have the other social determinants improved? When you've been on buprenorphine therapy and you've engaged in some psychotherapy, is your life stabilizing? Is home life better? Do you have home security? Do you have healthy relationships? Do you have food security? Are you reaching your educational goals? If those are being shored up, then it's time to say, do we want to talk about maybe tapering off of some of these medications? Because again, in every other chronic condition in the United States, we realize that lowering doses when possible with the safest med is possible. Now, maybe a day will come with a lot of people, the brain heals enough that we can move on to the protection phase. Meaning maybe we can taper down the bupe to where we use something like Vivitrol to protect the person from opioids, from alcohol, and that allows them further time to build up the other parts of their life so they can get to a thriving phase. I know that sometimes people hear medication first as medication only, and we'll talk about that in a moment. But I think what's very important to think about with this graphic on slide 29 is we never want to push people from an effective form of one medication to the next. If somebody's doing well, for example, on buprenorphine and they're not ready to move to naltrexone, we should not come up with arbitrary guidelines and deadlines on how long someone can be treated if they're doing well. In the past, we've done a lot of disservice to patients saying, you can be on methadone for a year, you can be on bupe for 6 months, and then you're off. That's an area that we have to do much better with, and we need to find better ways of figuring out what's a typical period of time in which people do well. But this is where the patient-centered approach comes in.
So meaning that there isn't a set titration schedule for every single patient if someone starts on methadone?
There certainly is not, at least at this point. Unfortunately, what I think we've seen a lot is that people don't offer titration. People don't offer the idea of what might your treatment course look like. I think in the past we've done a disservice to our folks because a lot of our patients, because we've arbitrarily said 6 months should do you, 1 year should do you. A lot of our work now working with treatment courts is helping judges understand this and realizing that if somebody's done well on bupe for 3 months and have had negative drug screens, it doesn't mean that they've done well, so you need to stop their bupe. It means they've been doing well, so let's refer back to the therapy team, the health team, to see what else is going on with their life. So my challenge to people who are engaged in our call today, we have to move forward to a more holistic model of care when it comes to folks with substance use disorder. It's not a surprise to anyone on this call. I think, in fact, a lot of people signed up on this call because we realize the intrinsic nature of people, of professionals working with folks whose lives have been affected by trauma and substance use, realize how this is intertwined. We have a broader public awareness of this than we've ever had before. Right now, we also have an influx of money, which we have to use responsibly and use this money, especially right now, to build programs and models of delivery based on evidence, not based on feelings, based on evidence, based on research, and based on program evaluation. And we also can't let our system inertia get in the way of creating the practices we need to have to help people move forward. Everyone on this call probably has worked with a system before that has various levels of inertia. I'm a family doc who's done this work in corrections, who's done this work in healthcare systems, and we can know what the science is and what the outcomes are, but it doesn't mean that that's necessarily going to drive system change. There are limitations and unintended consequences of our current treatment models. As I've mentioned before, Harm reduction is essential. It's something that we need to better understand. On the second bullet point, I inadvertently flipped these two, but we need to move from harm reduction to harm elimination and harm avoidance. Let me give you an example of this. Harm reduction. If someone participates in syringe access programs, we know that people are 5 times more likely to engage in treatment. Again, not new stuff. We've known this since the late 80s. The CDC has advocated since the late 80s that we should have syringe access programs, because the magic of what happens in syringe access programs is the interaction between the individual seeking syringes and the community health worker providing the fresh syringes. It's that evaluation and the encouragement for healing and sobriety that happens. Harm elimination comes in is when we can get someone on a medication that someone can engage so that they are protected from opioids, they're protected from fentanyl, they're protected from other areas, other substances that can kill them, and then eventually to where someone can move forward to where they can, on their own, avoid negative consequences of substance use because their brain has healed, their chemistry is regulated. Therapy is key at all points in this. In the current and past treatment models, we have done a lot of things to make treatment unattractive for folks or inaccessible. We've criminalized treatment, we've moralized treatment, we've medicalized treatment, which is one of the things we have to be very careful of today. We overemphasize pharmaceuticals. There are no magic bullets when it comes to pharmaceuticals, or else we'd still be trying to figure out the best way to work with addiction. We've also commercialized models of care in addiction. And a lot of times, we've told people that we've thrown everything at you that we can, and that we blame the patient. Treatment models still are not very standardized, and they're often not based on science and evidence. A lot of the time that I do in working with Assisted Recovery Centers of America is working with practitioners and working with resources such as those at SAMHSA, those at NIDA, and other organizations to find out how can we simplify and standardize care so that we can then tailor it more easily to an individual's needs. That leads us to what other option do we have, and that other option is to humanize treatment by clarifying our goals. I would say that if we, as medical providers, do not work with folks to help them have the least effective dose of medications with the safest medication, we're still not providing the best care that we can do. We need to be very clear with our patients as soon as the brain heals. What are some options for treatment? What are your goals? Where would you like to see your life go after engaging in medication and therapy? Because if we just put people on methadone and give them no other option, or just put people on bupe with no other option, we're essentially creating a palliative condition where we've told people, you cannot get better, you cannot change, so instead we're going to keep you at this fixed dose forever. We have several resources here that Sean and I have put together to share with you. And at this point, I think we'd like to see questions and comments from our participants. We purposely wanted to leave plenty of time for people to talk about this because we thought this would be a unique forum to bring together folks working with trauma and people working with substance use disorders to talk a little bit in a safer environment about how these conditions are related and the similarities in moving forward.
So this is Carol. Can you hear me?
Yes, we can.
Okay, so I'm going to moderate some of the questions. I'm going to, and thank you so much for this really great presentation. I'm going to ask you the 3 questions that were in the chat box, and then also ask some other questions that Dave and I were thinking about as we were chatting. So, but the first one was from Jennifer, and she said it would be great to hear about your thoughts on medication-assisted treatment for perpetrators in the justice system and availability issues. It seems that MAT just isn't available to people wrapped up in the justice system. Not sure if you plan to talk about it, but many survivors and their perpetrators end up in the system and then receive no treatment.
Thank you for that question. That is one near and dear to my heart because of my work in corrections for many years. My work in corrections occurred in a jail setting. I think in a jail setting, we need to be far more aggressive about providing medication-assisted treatment because the vast majority of people who are in a jail are going back to their community. And if people are in a jail setting and they don't have either the treatment of an agonist or the protection of an antagonist, if they're released from jail, the overdose rates are astronomical for people in their first 7 to 30 days because people go back into the same environment they came from. And why would they make a different choice if their environment hasn't changed and they haven't had any interventions? I'm looking forward to working with the St. Louis County Department of Corrections as well as in the city because part of the state target response funding that we have in Missouri, we will apply towards initiating treatment in the jail. What I would recommend is low-hanging fruit in a jail setting is if somebody's on Vivitrol, keep them on Vivitrol. If someone's on Suboxone, keep them on Suboxone. Same thing with methadone if it is geographically possible. If not, coming up with ways to provide bupe after a very gradual taper. One of the places to look for the work that has been done extremely well in the U.S. is in Rhode Island. Rhode Island's a little different because it's small, but Rhode Island has a very effective MAT on-demand program that they have some years now of very positive data, not only for the health and well-being of people while they're incarcerated, but upon return to the community.
Thank you. So I was going to add a couple things. Like one, there's the MAT in jail, making sure that people have it on release, both naloxone and MAT, and comprehensive treatment, which doesn't exist many places. There's a lot of work, like Stephanie Covington's work in prisons, that's gender-responsive, trauma-informed work that's, that addresses many dimensions of the intersection of trauma and addictions. And one of the things from her research that we've seen is that the reduced recidivism, in quotes, rate for women who are getting out of prison when they have comprehensive wraparound services are the same things that would have prevented them from being incarcerated in the first place if they had them on the front end. So there are many layers in this conversation. So I'm going to add, Peggy asked, what if a person has true pain due to an injury that will never heal? So I think that's about chronic pain management. And I know I was talking to a colleague recently who was saying that in their methadone clinic, in their addiction treatment clinic, they're seeing a lot of pain refugees who are getting methadone because they can't access pain medication anymore. So there's a lot of going on in that space. So what are your thoughts about that?
This is a great audience because you guys are hitting all the right questions. One of the things that I've been working a lot with some of the larger healthcare systems that are present in St. Louis is chronic pain. Because what we're finding is a lot of physicians are overcorrecting, and I even hate to say overcorrecting. A lot of physicians are just saying, I don't want the DEA or the state licensing boards breathing down my neck, so I'm just stopping prescribing opioids. That is wrong on so many levels. One, some people really do need opioids because of chronic pain conditions and other things. What we need to do, though, is find a few different ways to approach this. One is, are chronic opioids really helping people with chronic pain? And I'm specifically speaking here of non-cancer, non-palliative pain, musculoskeletal pain and other things. We need to find more substances, more medications, more tools to help people in chronic pain to increase their function. So yes, there is a role for methadone, there is a role for Suboxone, both in treatment of chronic pain, but we have to re-educate ourselves as clinicians on what those other tools are. And the other thing that comes with that too is when you have a state like Missouri that is not a not a Medicaid expansion state, or as I like to say, we're not a poor state but a cheap state. We don't cover outpatient physical therapy. So the only tool in the tool belt when someone's discharged from the hospital is a pill. So this is where the upstream work, like you mentioned before, in correctional settings is so important. We need to work together with policy advocates so that we can change policy around what our tools and possible interventions are.
Great. So let's see. I have the questions in one place and they're in the chat box in another. Diane asked, what about relapse after someone is weaned off Suboxone and has almost 2 years clean? Do they go back to the start? And someone, Doug asked, is being on Suboxone for 4 years too long? So there are two Suboxone questions there. Hello? Fred, did you hear the two questions I asked? Hello?
Yeah, hi, Carol. This is Dave. Dave Shern.
Did you hear the questions
sorry.
I asked?
There.
Yeah, I did hear them. Okay.
Okay, great.
Two things. Yeah, we're trying to mute at our end, so we're cutting down on feedback. With the first question about can somebody go on Suboxone after they relapse? My response was, if somebody's blood sugar hits high on their glucometer, do we take away their insulin? No. We help see what was the problem, what happened so that the relapse occurred, what was different in that person's life, why were they in such a situation that relapse seemed a better choice than continuing on Suboxone. So the American Society of Addiction Medicine has a phenomenal definition, though way too long of a definition of addiction. The key is that we need to think of addiction as a chronic primary relapsing condition where we expect these things will happen as they do in every other chronic condition in the U.S. First answer. Second answer is 4 years on Suboxone too long. My question is, how is a person doing on Suboxone? Is their quality of life better than if they hadn't been on Suboxone? Is life improving? One of the things that we've learned is that if somebody's life is better on Suboxone, great. I would certainly say that on a regular basis, every 3, 6 months, maybe a year, depending on what else is going on in that person's life, see if they offer them an opportunity to taper. Make sure that you're hitting any other co-occurring substance use disorders or co-occurring psychiatric issues so that we're hitting some of the areas that might have promoted that use. And if there's nothing else that we're missing, there's no reason at this point to think that 4 years is too long.
Great.
Could I jump in for a second, Carol? This is Dave. A question for Sean, actually. Sean, as you think about trauma-informed approaches, kind of give us a sense of sort of in the context of working with people who have addiction problems, what some of the hallmarks of a trauma-informed approach might be?
That's an excellent question. And part of that comes to really utilizing, in my opinion, the core principles of trauma-informed care. So thinking about in our environments where we may treat substance use disorders, how is it that we're helping to establish safety, trustworthiness, choice, collaboration, and empowerment for those we have the privilege of serving? Recognizing that as we're thinking through some of these core principles, that oftentimes they're just seen through the lens of those providing the service and needing to broaden that lens, that as we think about these core principles, that they also have to be through the lens of that individual coming in for services. So as we think about safety, oftentimes within an organization, we really just limit that to physical safety. But what are we doing to ensure individual psychological safety as well in that setting? Thinking about how can that person fully engage in treatment if they don't feel physically as well as psychologically safe.
And I was just going to add that Sean and I had a really interesting discussion last night when we were going over the slides for this presentation about maybe what some of the traditional models in treatment are in terms of therapy, in terms of intensity of services and where that intensity is. And I think that speaks to some of the trauma-informed approach to treatment.
So as we're thinking about an individual's treatment, historically in traditional models, we've thought about the most intensive time of treatment was during that time that the brain was healing, that person was trying to establish that safety. Thinking about the greatest need for support might be after we get an individual in a place where the brain has stabilized to ensure that there's supports and really supports for continued success.
I have a few more questions from the chat box. One was about from saying this is a great talk, and I wish you could redo the same talk and include research on brain injury and its effect on increasing the chance of PTSD and addiction. Could you comment on which medication is best used with someone with brain injury?
I think the medications here, that is a wonderful question. I think we stick with the same kind of medications for the addiction piece. I think the bigger thing to think about, though, when we talk about TBI and perhaps permanent damage related to TBIs, would be the fact that the healing process is going to take much, much longer. And somebody who might have a coincident use disorder and a brain injury and usually a behavioral health issue related to that as well, we might have a point where we need to get the medication right, and the medication might need to stay on board longer. And what I mean by that specifically, someone with a traumatic brain injury, they might need to stay with agonist therapy for quite a while, if not the rest of their life. Those are the kind of issues that we're researching right now through some brain imagery and other tools that we haven't had in the past.
Great. You know, there's one thing I wanted to bring up. This is Carol. One of the things that one of our things that we talk about when we talk about substance use coercion, where an abusive partner actually coerces their partner to use or sabotage their recovery, exposes them to substance after they're out of rehab, is that when we think about the relapse triggers and the neural pathways that are involved, that are exposure to addictive and rewarding drugs, conditioned cues from the environment, and exposure to stressful experiences that activate the rewarded incentive salience and glutaminergic pathways that you've been talking about, and including dopamine pathways. So it's like thinking about the social environment and the neurobiology and how they intersect. And so, intimate partner violence and coercion is one aspect, but there are many other kinds of environmental cues. And so thinking about them together, not just separately, I think is really important as we're creating a more comprehensive approach. And that leads into a question from Maria Ross, which was, what would be a more systematic approach to addressing opioids from the social services and medication services perspective? How do clinicians and social services work together to address addiction and social determinants?
So I think part of that is in thinking also upstream and in thinking about what are our community approaches. So if we think about the co-occurrence of trauma and substance use disorders, thinking about the hurt that people experience and how people are attempting to mitigate that hurt or that lack of safety that they're feeling. So really thinking about community approaches to addressing trauma and toxic stress, recognizing also that we all have a part to play, and in playing that, thinking about how do we develop true community solutions and solutions that aren't developed by social service agencies, but really interventions that are developed by community themselves, recognizing the power of community.
And on a clinical level, for people whose lives have already been addressed, whose lives have already been affected, a couple of the things we're doing at St. Louis U that I think speak to this. One is normalizing conversations around substance use disorder and trauma. For example, in our clinical interviewing course with our first-year med students, I got to take this course over last year with a colleague, and we organized the course based on social determinants of health. So that rather than playing games to talk to patients about what kind of headache do you have based on symptoms, we focus on how do you have a conversation with a patient based on the chief complaint and what you two need to discuss about the chief complaint to get the relevant information. The other thing that we're doing at St. Louis U is we have a very robust interprofessional education program where we're teaching healthcare professionals from 7 different professions the communication and team-based skills that they need to understand what each profession brings to the team and what each profession can create to get the outcome and safety measures we need for individuals by working with the patient. So there are pieces in place upstream that Sean mentioned that is so important to create a healing and healthy community, but there's also things that we can do to change the way we're training our providers and creating more effective workforce development.
Great. So now there are some more questions. One is about, is there much conversation about mobile treatment in the substance abuse treatment field across the nation? Advocates for survivors of trauma are using mobile advocacy models in greater numbers to meet people's needs. Is the treatment community seeing the same need? And there are also questions about using marijuana and CBD oil. Is that dangerous for treatment of chronic pain?
Okay, mobile units, yes. The more we can get health care to the people, to our communities, and it's integrated into the fabric of communities, the better it is. A friend of mine, a colleague, has a dream of having a mobile methadone unit, but I think there's a lot of interesting things we can do in terms of community outreach, and I hope to be investigating some of those in the future. But here's one just to give a teaser. If we think about naltrexone as a protective tool for people who are off of opioids and off of alcohol, but live in environments where they fear relapse, we could think of oral naltrexone much as we think of PrEP for HIV. That's just an idea. Now the other idea, cannabis oils, etc. Here's my standard approach to that answer. Yes, there is much we can learn from research in cannabis, and we have some now FDA-approved medications that come from cannabis, including the oils and including for intractable seizures among children, etc. However, my concern about calling cannabis that we have legalized today as medical cannabis, there is no other medication in the United States that we have variable potency, variable purity, and we have to combust in order to use. I think it's worth exploring to continue to get some good medical research like we do with every other intervention, because I think there's much promise there. But I'm also very interested to see what the rates of COPD and lung cancer will be in Washington State, Oregon, and Colorado in 10 to 20 years.
And I'd like to quickly look at the mobile treatment unit philosophy. I also want to recognize that As we think about our systems, even our institutions and organizations providing quote-unquote treatment and services, that sometimes those systems have not approached all people with equity. So we have to also recognize the inherent mistrust there may be in the system as a result of some of the historical trauma that's been perpetuated. So finding new and unique ways to meet community, to support community, and making sure that we really have an understanding of inequity so we can provide equitable outcomes for all of our communities.
Great. So there are two more questions. One is self-medicating. Can you address self-medicating due to violence? And the other is a question about neonatal abstinence syndrome and suggestions for how to educate child protective service workers on this information to help in that more holistic response for women with substance use disorders.
Okay, self-medication and then neonatal abstinence syndrome. Okay. As I tell my students all the time, in St. Louis, it's a lot easier to run to the grocery store and get a bottle of bourbon than it is to get an outpatient psych appointment. So a lot of the folks that I cared for years, both the adults and the children in criminal justice in St. Louis, were self-medicating. They could better control their mood, they could control their neurotransmitters, they could turn off parts of the brain that hurt by self-medication. Again, part of the reason why we need to normalize conversations around both behavioral health and addiction issues. So yes, self-medication is very, very common in the U.S. That's why when people look at studies in Europe versus studies in the U.S. on issues of addiction, we have to realize one of the biggest differences we have in terms of safety net is our healthcare system in the U.S., however we want to describe that, versus universal access to care in almost every other developed country in the U.S. Neonatal abstinence syndrome. There are some very positive practices that are occurring around that area. It is not my area of expertise, but if you want to look at ACOG, which is American College of Obstetrics and Gynecology, they have embraced MAT and ways to use it effectively to keep the mom and the fetus to baby healthy during pregnancy. Another great place to look is the WISH Center, W-I-S-H Center is the one I know best here out of St. Louis at St. Mary's Hospital, where they have found very creative ways of minimizing the effect of opiate withdrawal for neonates. And surprise, surprise, one of the most effective ways is to co-room the baby with the mom rather than separating them and putting the baby in a high-needs nursery. So there's some very good work being done out there about how do we manage that together.
Right, and the American Academy of Pediatrics also has a policy piece on that as well. So,
and also, just speaking of pediatrics, colleagues of mine and I just recorded a current CME for physicians on adolescents and opioids that should be coming out in the next month or so.
Great. So how do you address the stigma associated with treating people with addiction? Oregon has seen an increase in, I can't see, it says X-waiver providers prescribing at least one fill of bupe. However, that rate is still only approximately 50%. So I'm not quite sure I'm interpreting the question correctly. Savannah, do you want to clarify in the chat box if I didn't ask it the way you intended it? And there's one other question. If there's time, Catherine wants to hear about if there are any sex differences in the process treatment medication use. Does this apply to men and women equally, or are there differences? And I know there are some differences in some types of medication treatment for substance use. So if you could address that.
Yeah, we love that question.
So starting with the stigma question, and I think it first has to it first comes down to rethinking substance use, understanding the larger context of why someone might be more vulnerable to using substances, really infusing and utilizing the brain science in this process. So shifting away from old paradigms where we really label substance use as some type of moral failing, as someone being bad or wrong, and starting to understand and really utilize the brain science, and then interweaving then the science of trauma to understand why someone may then be more vulnerable to substance use. So part of it comes to understanding science versus looking at this through a lens of morality, in my opinion.
Okay. And then we can move on to the differences in sex differences between the two medications. Part of it is just metabolism. Metabolisms are always slightly different. And in general, we're going to see dosing vary a little bit because methadone and buprenorphine are both processed and metabolized through the liver. I think the most important thing at this point in the United States when we talk about FDA work is naltrexone and naloxone are contraindicated in pregnancy right now. However, a lot of studies around Europe are showing safety and efficacy with that. So we tend to be careful about the way things are right now. We don't prescribe Suboxone, which has some naloxone present in its delivery system, or Vivitrol for pregnant women. That will likely be changing in some years ahead as we get more data, because it doesn't seem like there is a teratogenic effect. And also, if we look at risk-benefit, I don't think it makes a big difference. And I can let Sean answer on trauma. Do you want to comment on trauma treatment between men and women or differences?
So one of the things we want to recognize when it comes to understanding trauma is that we want to give credence to the fact that men and women, or male-bodied or female-bodied individuals, may experience different types of trauma, but also recognizing what is the gendered experience as we think about in a journey of healing and moving forward. So thinking about how is it that when we think about a male-bodied individual versus a female-bodied individual and certain social standards, expected gender roles, and how that might then stall someone's process or journey of healing. So having that gendered understanding is going to be very crucial in terms of supporting someone in their journey of recovery from trauma.
So there was one last question about using MAT in a jail as opposed to a prison where people might not be there for that long, and would you recommend that getting started?
Yes. Any work we can do with folks behind bars, if they're imminently coming back to the community, I think is worth doing. Some people would do well on Vivitrol. Vivitrol is used quite a bit because it has been shown to be efficacious for people coming out of prison, or if they've been in jail long enough to get the opioids out of their system. However, we need to come up with effective tools to screen who is more likely to do better on Vivitrol versus who is more likely to do better on Bupe, in light of what their history with treatment is, in light of what their history of substance use is, severity of use, age of use, those factors. But I think there's a place for all medication, especially in reentry programs.
Well, great. Thank you. Carla, were you going to do the closing?
Thank you, Carol. Thank you, Fred, Sean, and David for today's webinar, and thank you, Angelica and Carol, for making the webinar run smoothly. Last but not least, thank you all for spending your time with the center. Within the next week, we'll send you all a follow-up email with a link to today's recording and the handouts reference, all which will be available on our website. You'll also receive a certificate of attendance for your time today. And if you have any questions that we could not get to, please reply back to the email I sent out. At the end of the webinar, you'll be taken to a very brief evaluation. If you please take a moment to let us know what was useful and what could have been better, we would greatly appreciate it. Thank you again, and have a wonderful afternoon.